Hi, I'm Amber Barnato, and I'm the Susan and Richard Levy Distinguished Professor of Healthcare Delivery at the Dartmouth Institute. I'm also a professor of medicine, and I'm a fellow in palliative care here at Dartmouth-Hitchcock. I think all of you know that the Dartmouth Institute has made a major impact on U.S. healthcare policy, but a story that not that many people know is that it's made a really big impact on my own life. When I was an intern in general surgery, that was back in 1994, I experienced a profound amount of moral distress with the experience of kind of connecting people to life support and keeping them alive in the ICU. Sort of felt like far beyond what would have been imaginable or preferable, without really ever talking to patients or families about what they really wanted to achieve, what their goals were. And I ended up dropping out of my general surgery internship because of moral distress. So in 1995, when I was living with my mother and trying to figure out what to do with my life, wondering whether I was going to quit medicine altogether and maybe get a PhD in English or something, I was driving along in my little Volkswagen Golf, and I heard a story on NPR. And it was about the study to understand the prognoses and preferences for outcomes and risks of treatment, or the support study, which was done by several investigators here at Dartmouth, as well as other folks across the US, trying to understand really this issue about how people with serious illness come to an agreement with their physicians about the care that they would wish if they might soon die. It was a landmark study, and the thing that it lit off in me was the realization that I wasn't crazy, that there were actually people who were doing research on this subject that had really kind of perplexed me and distressed me when I was an intern. So I set my life on a course at that point. I said, I'm going to become a researcher, and I'm going to do research studying serious illness, end-of-life care, and communication and decision-making. And that's what brought me to this point in my life. So I study how people die. Everyone has a story and an experience, right? Anytime I go to any kind of event or dinner or cocktail party and I tell people what I do, they immediately have a story to tell me about their grandmother or their uncle. And sometimes it's gone really well, and sometimes it's gone really badly. And that's something that we all carry with us forever. And so I try to develop understanding about what it is about the way that physicians communicate that leads to the kinds of outcomes that we see. So I focus on communication and decision-making, and providers are my primary study subjects of interest. So the question is, why is it that if you happen to get hospitalized for a serious illness on one side of town, instead of a hospital on the other side of town, you might be more likely to be connected to life support at the end of life? And so I use basic behavioral decision science to try to leverage insights into the ways that doctors think. In particular, what are the implicit or unconscious biases that drive them to, for example, have an advanced care planning conversation with the patient, or consider whether or not talking to the family at this current time would be appropriate, or whether it would be something that should happen later on. And so I'll try to give you an example. I just completed a study not long ago with the state of California, their Medicaid program, which is called Medi-Cal. So I worked with a very large health plan in Northern California that was already paying its doctors $100, basically a bonus, to have advanced care planning conversations with patients over 65 or who had serious illness. And that $100 is pretty meaningful when you think about Medicaid payment rates, which for just a regular, visit might be closer to $30. But they weren't really seeing a budge on the numbers of advanced care planning conversations happening. So I proposed to them, using, again, one of these principles of behavioral economics. I said, well, I wonder if we could pay the patients the money instead of the doctors, or in addition to the doctors, because they're really the ones who are doing the hard work. I mean, they're doing their homework, they're talking to their families, they're thinking deeply about what matters to them most to be prepared for that advanced care planning conversation. So what we did is we ended up paying the doctors $100 per advanced care planning conversation if they had them, so that was kind of their bonus. But we also gave $50 to the patients if they would have the conversation. and we would enter them into a lottery to win $1,000 if they completed their conversation. And the interesting thing is we found that with giving the $50, it increased advanced care planning rates by double, but it wasn't by the mechanism you would think. It wasn't because the patient said, oh, here's $50, I'm going to go do this. What happened was the doctors were more likely to initiate advanced care planning conversations with their patients when they were in the arm where the patient would get $50 because they wanted to do something nice for their patient. They wanted to give their patient that $50 gift card because it was like meaningful to them. And so it was kind of an unexpected finding, and it's something that's consistent with, again, social behavioral processes where we say, okay, well, we think that there's these financial incentives, and we're trying to pay doctors to change their behavior, and we're using financial motivations. But what if we can use financial incentives basically to increase physicians' altruistic intentions, right? Their ability to give a gift to their patients. Because it turns out that regardless of which arm you were in as a patient, if you were in the arm where you got the $50 or the arm where you didn't get the $50, it didn't matter. What mattered was that your doctor brought it up. And as long as your doctor brought it up, you were going to do it. But your doctor was more likely to bring it up if they were going to give you a gift, in addition to having this kind of uncomfortable conversation potentially. So that's an example of some of the research that we've done. I've got another couple of really cool projects that I've been working on where we're using serious games like video games to try to change physicians' heuristics or intuitions around particular cases that they under-recognize. And that's been really fun work because what we're able to do is we engage physicians in playing what we call a serious game. So it's kind of a pro-education game. And we shift unconscious ideas about particular severity of illness and when it's time to make one decision versus another. And we're actually showing that we're increasing the likelihood of physicians doing the guideline recommended behavior when we compare that to just text-based education, the usual kind of education that we give physicians. And we think it's because the immersive experience of playing a game and participating in basically an adventure story online actually makes the information stickier because it's more memorable. So we've got work in that vein published in the British Medical Journal, and we're actually under revise and resubmit for another project, the Proceedings of the National Academy of Sciences, the PNAS, which is a journal that health services researchers never get published in. It's usually for basic scientists. So those are some of the kinds of things that we're doing, and we're really, really excited to keep working on this effort to try to improve the care of patients with serious illness so that they don't feel traumatized by this phase of life, but they feel supported through it. And I feel like Dartmouth is a place where this kind of work can have real national impact.
Amber, thank you so much. That was a wonderful presentation, and I really have an appreciation for the challenges and benefits of the work that you're doing. One question comes to mind, which is, does your work accommodate differences in patients? Maybe it's a generational piece, where you have some patients who revere doctors and will want direction from them and just follow direction and don't want to have to be their own advocates, versus those patients who actually will have a conversation with the doctor and think of ways that together they can make a better decision for the quality of care at the end of their life. I'm just curious about that.
Yeah, no, I think that's a really interesting question, and this is a place where my work as a palliative care fellow is really going to be is really enriching my research, and it was one of the many reasons that I wanted to do a palliative care fellowship at this stage in my career. One of the key recommendations of conversations regarding advanced care planning is to try to understand what people's decision role preferences are. What preference do they have for engagement in the decision making? We have a normative belief that everyone should share in the decision, but that comes out sometimes in a very, I guess you would say, kind of like a mechanical way. I would say something like, this is your decision, so let's decide with me. It would be another thing entirely for me to try to get to know you as a person, to ask you about what matters to you most. What are the things that bring you joy in your life? What is the minimal level of function that you would have to be able to have to feel like your life was worth living? I could get that information from you. I could hear that, for example, you like to crochet, or that you enjoy hunting, or that you like to walk your dogs daily, or maybe all that you need to be happy is a really good novel and a sunny day. And so I can take that information and I can look at what's medically achievable with a couple of different options, and I can say, if those are your goals, option A is not going to get you to a place where you can be hunting again. But option B could, right? And so that might be the way in which you participate in a shared decision-making process with me, and then I'll make a recommendation to you. I said, based on your goals, I think we should go with this one. And so you've given me something that's important because it's not just an objective decision between A and B. It's about what's medically achievable, and I know that because I'm the doctor, but you're the only one who knows what your goals and values are. And so that's how you can actually get to a shared decision without actually requiring someone to participate in the decision directly by saying, what's your decision? And so, again, this is what I've learned in clinical practice, and thinking about the ways that you can get that into broader clinical practice, it would be a key goal of mine.
Thank you.
And this is really terrific. You had a great presentation. And at the end of your presentation, you said something about having a future impact across the country with this research. What do you see as a future state of how you would like to see the provider and patient relationship and communication across the country? If you could think bigger and if you got the funding today to do what you want, what would the end state look like for you?
Yeah. I mean, I think we need to completely redesign and reimagine healthcare delivery. And I mean completely blowing everything up. Right now, we see healthcare as this transaction between providers and patients, usually in a healthcare environment. But patients have these lives, right? These trajectories and experiences. And we're just dropping in and out in these moments in time. And so I'm imagining a way in which we would completely redesign healthcare, right? And we would start with the patient and the family and the community, and we would think, okay, here's a situation, a patient with advanced cancer. Okay, how would we achieve the goals of we have different goals. The healthcare system has its goals, the patient and the family have their goals. How can we basically redesign and reimagine healthcare to meet those goals? And it might involve entirely sort of changing the way that we deliver healthcare. Now, some of my colleagues at the Dartmouth Institute who work in microsystems are actually doing some of this frontline innovation, in part with key contributions by folks at Tuck. And we're doing this with palliative care right now. We're basically trying to say, okay, we think as palliative care providers, we're particularly thoughtful. We think about goals and values, but we still work in these environments where patients come to us in clinic, or we see them in the hospital, or we meet them in the infusion suite for oncology. And we're kind of adding ourselves on top of the existing infrastructure that involves oncologists and infusion nurses and social workers and physical therapists. Is there a way that we could redo this completely so that we have the patient at the center and we still achieve optimal healthcare outcomes conditional on the treatments available? But we don't have to do it in the existing infrastructure. I mean, we are limited right now by what we have in terms of our built environments, but I would imagine that in 10 years' time, things like hospitals and clinics will start becoming obsolete.
Wow. Well, that's powerful, and we certainly wish you all the best in this research, because we definitely do need to rethink the way we deliver healthcare in this country. So we really appreciate your time.
Thank you.